My wife's grandmother is today, on the day you're watching this video, in an intensive care unit in critical condition. And how did this story begin? One Saturday I was getting ready to go to church around 6:30 post-meridium. My mother-in-law sends a message to my wife saying, "My mom isn't doing well. Can you go over there to check on her? They're not able to check her oxygen saturation and she's not doing well." My wife's grandmother stays in a long-term care facility due to several reasons to be taken care of. Her daughter, who is my mother-in-law, is also elderly, so she is cared for in a long-term care facility. But I said, no problem. I'll stop by there and then I'll go to church. It's fine. So I said, I'll stop by the company, pick up the Protec Oximeter, which is the TCR handset, and I'll take it, check everything, see what's going on. So I stopped by the company, grabbed the device, and got to the place. Guys, when I saw the patient, you wouldn't believe how she was. Before I continue, every Tuesday at 5 p.m. we're doing it live, so if you want to watch, it's at 5 p.m. If you want to watch it again, you need to be a member here on the channel. Take advantage and participate in the polls in the community. The thematic choice for the live session is made based on requests and voting within the community. Here on YouTube, you can participate easily. All right, let's go. What happened when I got there, guys, was that she didn't know me. In other words, she didn't recognize who had arrived. She was lying in bed, breathing like this, look. Tachypneic breathing, noisy breathing, really noisy. Pale, you could see that her extremities were pale. And I grabbed the oximeter, put it on her finger and said, man, the patient is not doing well, really. The patient is in serious condition, not doing well. It's different from a regular serious patient. I put the oximeter on her finger. It took a while to get a reading because the perfusion in her extremities was so low. And when it finally got a reading, we noticed the curve was really low, the curve was really bad, and the oxygen saturation was at 83. And then the nurse who was there said, look, we tried. We even bought an oximeter. We bought it because there wasn't an oximeter in the pharmacy. You know, that crappy thing that costs around 100 rays. That thing is only for you, if you're okay, to put on your finger and check. For an important patient, it won't work. I've already shown videos here, and once again, we proved in a really bad way that for a patient who really needs to measure their oxygen saturation, that crappy thing doesn't work for low perfusion. In other words, it only works for people who are okay. For those who are not well, it doesn't work. Anyway, I asked her, do you know what's happening with the patient? She said, he's got an increased heart rate and a fever. I said, no, the patient is basically in sepsis, elevated temperature, increased tachycardia. The perfusion is low, slowed down. I didn't check the blood pressure, but given the whole situation, there was a compensatory mechanism, not to mention the classic respiratory symptoms of a patient who is entering or is already in sepsis. You came here to lecture me? Come on, nobody was born knowing everything. But you look at a patient in that condition, call the family, talk to the family. Saying the patient isn't doing well is different from a patient who's just feeling unwell. The patient wasn't doing well. The patient was in serious condition. I said, look, I came here because if you had a proper oximeter, you would have checked the oxygen saturation. That's why I came here. Because if you had been able to assess the patient, you wouldn't even have sent a message to the family because the patient wasn't doing well. You should have already called the ambulance. That's what she did. She called the ambulance and the ambulance staff got worried. She already had 70% oxygen saturation. The ambulance took her to the hospital, and when she got there, she was taken straight to the red room. When I got to the red room, she had already received an antibiotic, vancomycin if I'm not mistaken, and they had put a non-rebreather mask on the patient. It wouldn't help much, but they put a non-rebreather mask at 15 liters. Then they removed it and put on a nasal cannula. Her problem wasn't the oxygen itself, but her saturation was low. This is something we need to discuss. In another video, maybe a live one, suggest it or vote in the community so we can do a live session. So what happens? I noticed that those who were in the red room, unfortunately guys, I have a big problem. I look at people, I can tell if that person gives off a sense of security or not. And when I looked, unfortunately, the professionals who were there didn't seem trustworthy to me. But I thought, this must be just in my head, I need to stop with this habit. But unfortunately, what I had thought happened. What happened? The patient's blood pressure dropped, she became unresponsive and needed to be intubated, and they asked me to leave the room. I knew the nurse present couldn't operate or turn on the mechanical ventilator. The nursing technicians who were there obviously wouldn't know, and the doctor, frankly, she's not an emergency physician, but I left, of course, respectfully and waited outside. 30 minutes went by. 30 minutes for a proper intubation sequence. It's a while, okay, but it could have taken even longer. And I look, because the door opened, it stayed open, so I looked. They intubated her with a laryngeal mask. Did you understand what a laryngeal mask is? Laryngeal mask? We intubate when we don't use laryngoscopy with an endotracheal tube. In a street situation, even in a hospital setting, by trained and qualified nurses and also doctors, but in a situation where it's really necessary to do it. But laryngoscopy was attempted with a size 7 tube. What's the problem with a size 7 tube? The patient has a short airway, a size 7 tube doesn't fit. And the nurse needed me for her because she and I had already worked together in this hospital, she said. Eder, there's no tube smaller than size 7, man. How can a private hospital not have tubes of different sizes? In an emergency cart, in an emergency, that's right. Since she couldn't intubate because the tube was thicker than the patient's airway, she used a laryngeal mask. So, the doctor later said that the patient had a laryngospasm, that's why she used a laryngeal mask. But, guess what? A whole team arrived from the intensive care unit, doctor, nurse, physical therapist, and nursing technician, spent about 10 minutes, and the patient ended up with an orotracheal tube and the mechanical ventilator properly set. Then the intensive care unit doctor came to talk to me along with her, and I started asking some questions to understand what had been done there. But, already suspecting that something had been done outside of what was supposed to be done before, he said, "Oh, she had laryngospasm. Okay, she had laryngospasm, and then you put in a laryngeal mask, I see," and so on. Then I asked what the mechanical ventilator settings were, and the intensive care unit doctor said, "No, that's with her." Then I looked at her and she said, "What are the mechanical ventilator settings you put there?" She looked at me and said, "You're from here, right?" I said, "I'm an intensivist." I didn't say I was a nurse or a doctor, I just said I'm an intensivist, because I was already running a bit short on patients, you know? She said, "No, you have to check with the physio." But the physio had already been there. In other words, the intensive care unit doctor had come down and I asked about the value, the ventilation parameter, and they didn't know. In a private emergency room, I asked what kind of sedation and analgesia the patient was on and was going to receive, so rapid sequence intubation was not performed. Guys, this is the reality of today's emergency professionals. I wanted to believe that she was really good, or at least good enough to handle emergency care. But I looked and said, man, I don't think this doctor here is up to it. I wanted to be wrong and that happened, but it can get worse. I'll tell you in episode 2 tomorrow. I'll continue because the story is long. You still don't know what happened in the emergency room? There are things you'll even learn so you don't let this happen to your patient. I'll see you tomorrow to continue.